Welcome, everyone. We thank you for joining us this evening. My name is Andrea Allen, and I'm president of the Alumni Association at the Factor-Inwentash Faculty of Social Work. Thank you so much for joining us. Our topic this evening is harm reduction, not what you thought. And we have a wonderful panel of speakers to share with you this evening. Prior to that, we'd like to start with our land acknowledgement. I wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, this land is still the home of many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work or live on this land. We all have responsibilities to be active players in decolonization, of which we enact each time we are learning, showing up, speaking up, and staying informed about the needs and desires of our Indigenous comrades. I must acknowledge people like myself who were brought across the Atlantic without being given a choice. People who were brought on the transatlantic human trade ships. We all must acknowledge other nations who came to this land for the purpose of colonization, of which some have forgotten that they're settlers. We give thanks to the Indigenous ancestors for their patience, but acknowledge that it has been exploited. Can we take a few moments and reflect on the Indigenous people who have been misplaced as we stand and work on their land? We acknowledge this land and look forward to our Indigenous brothers and sisters' reclamation. Thank you. I'd like to introduce our panel as I see people are still arriving. So the first panelist I'd like to introduce to you is Michelle Lewis. Michelle Lewis is a dynamic leader and educator with over a decade of experience in the health services sector. She's a registered social worker who holds a social service work diploma from Humber College, a minor in psychology from Toronto Metropolitan University, and a master's of social work with specialization in health and mental health from the University of Toronto. Michelle specializes in planning and the delivery of healthcare for people presenting with complex mental health and addiction profiles. Michelle values and upholds anti-oppressive practices. She is passionate about health equity and advocating for access to high-quality holistic health care for marginalized equity-seeking populations. Our second panelist is Hope Ramsey. Hope is a senior healthcare executive and community health researcher with over 30 years of experience in the design and management of community health programs focused on sustainable improvements, stakeholder value, and bottom line impact. Hope is currently the executive director of Moyo Health and Community Services, where she leads teams in providing respectful and destigmatized array of health promotion, education, mental health, social and support services for people living with and affected by and at systemic risk of HIV and other sexually transmitted and blood-borne infections. Our third panelist is Joanna Dickinson. Joanna Dickinson. Joanna Dickinson is a primary care health practitioner with over 12 years of experience in community and residential settings. She works exclusively with individuals who are experiencing mental health and substance use concerns. Currently, Joanna specializes in addiction medicine, working at a rapid access addiction medicine clinic at CMAH. During her time as a nurse practitioner in family medicine, she recognized the abundant mental health needs of her clients. Candice Brimner is our fourth panelist. Candice is a Bachelor of Social Work and a registered social worker and has worked in the social service sector since 2010 in a variety of frontline and health roles. Currently, she's a registered social worker at one of the leading teaching hospitals in Ontario and maintains a small psychotherapy practice in Hamilton. Candice is passionate about her work and not only utilizes theory in her practice, but also her lived experience as a woman in recovery from mental health and substance use. I'd like to turn the moderation over to Michelle, who will moderate us through this session this evening. Thank you.
Thank you so much for the introduction. I appreciate that, Andrea. I do have a number of questions that I would like to pose to the panel this evening. The first question is for everyone on the panel. I want to ask you, what are your views on harm reduction and how is it integrated into your current role? And if you can also talk about key learnings that you've experienced as a result of this work.
Maybe I can start. I'll back that up a little, Michelle, and I know, thank you, Andrea, for introducing me and the other panelists, my colleagues here, and it's great to be among such a wonderful group of social workers and social work-minded people. So very, very grateful to be sharing the panel with my colleagues today. I think before I answer that question, one of the things I want to talk about is who we are, who am I, what brings me to this. You know, I think, and that will help the panelists. I am not a social worker. My background is in nursing, just so everyone understands, and my graduate degree is in public health. However, because I have been working with a lot of marginalized populations, one of the privileges that I have had is to work on harm reduction programs. And I use the word privilege intentionally. So what brings me to this? It's the fact that when we think of harm reduction, I'm coming from a background where people were always condemned. We use and hear words like drug users, those drug abusers, people who, you know, have nothing else to do with your money and they're going to be stealing. And I thought to myself, it just cannot be. It cannot be that people who use substance should be labeled in these ways. And so it piqued my curiosity, not just from working with people who were living with HIV, but recognizing that people who use substance were also at greater risk of exposing themselves to HIV. And those of us who've been around for a long time, I see someone like David Lewis on the as one of the attendees here, we know that there was a time when the exposure was mainly through injection use, right? And we've transitioned, which I'm sure Candice and John are a lot more equipped to speak about. But what I thought was that we've got to see people as people, rather than have these condemning, judgmental attitude. And so I set out on a path to say, you know what, if I can make a difference, I'm going to do that. So I know many of us know the story of the star throw, right? We've heard the video. We've watched the video, we've heard the poem about this young guy who was walking along the seashore and a lot of starfish were on the sand. And he was just walking and throwing them in. And this gentleman came along and said, young man, what are you doing? He said, I'm throwing these starfish back into the sea. And he said, look, the vast number that are on the sand. How can you do that? what are you doing? Can you make a difference? And he said, you know, I can. It made a difference for this one and this one and this one. And so when I learned that poem and then later watched the video, I thought to myself, you know what? I'll never be able to correct the way people think or people behave, but I can start making a difference where I am. And so when I got involved in harm reduction programming, it was to the chagrin of many people that I knew, including my own family. So my biggest learning coming into the field was understanding that I may never be able to change everybody's mind, or if I start with me, then having a language and an attitude and a practice that says everyone is valuable, that I can help to make a difference one person at a time. So I will just stop there and throw it to another of my panelists.
Thank you for those insights, Hope. That is a very touching, inspirational perspective around how you came to this work. Does anybody else want to comment? Joanna, do you want to go next? Perfect.
Sure thing. So I'll maybe just tell a little bit about where I'm working. So I work at a rapid access addiction medicine clinic in the Peel Dufferin area, and also known as RAM clinics. And if you're not familiar, they are clinics specifically for people looking for any kind of help around addiction or substance use. And the common goal is that we try to provide rapid access and low barrier care for those seeking help with their substance use. And I was really drawn to learn more about this community because I really felt like there was such an opportunity to be a part of the community and to make a real difference. And I'm really with hope that, you know, we do have to start with one person and go from there. And I just wanted to share 3 kind of learnings that I've had over the past 2 years working with people who use substances. And then some of the things that I'm doing, hoping are contributing to change, because ultimately we do want to leave this system better than we found it for people who are using substances. So it's not going to be a big surprise to anyone that what we've learned is that the drug supply is toxic, and it's contributing to a lot of deaths. I recently heard it described as a black box, and I thought it was the perfect description, in that people have no idea what they're taking when they use illicit substances. And so that's really where harm reduction comes in. And we really need to have programs and services that are accessible and really meet clients where they're at. We can't have a prescription for where we want them to be. We have to know where they are and have them tell us how we can help them. And what has become apparent to me, and something that I've learned over the past few years, is that lots of people are not seeking treatment, that the models that we have, some of the treatment facilities, residential programmings, are not welcoming. People don't feel safe and they don't want to come to us. And so this is really one of the learnings and the things that is important to me, is how can I ensure that my practice and the community that I'm trying to help feel safe and welcome to seek care. In this role, I've had a great opportunity to influence how we are providing harm reduction services. And so this has been really exciting for me. So my 3 kind of learnings are that clients are experts in their own lives and their own care. And really what they're asking for is for information to make informed decisions. They really want a menu of options that I can help them provide, but they want to create their own treatment plan to create safety for themselves and their own community. And this is really important. The other thing that I've learned is that it's really amazing that there's lots of harm reduction offerings in different communities, but it's not universal. And so if you work in a community like myself that doesn't have a lot of the larger harm programs, all as clinicians need to create our own community of experts, and so that we can make sure that we have services to offer clients that are going to meet their needs. And this kind of really speaks to Hope's point, is that I've also recognized that clients have their own community, then they support one another. So if I'm able to share information with one person, I can be pretty sure that that information is going to be disseminated to many other people. So every interaction that I have with a client is really important. And the last learning that I've had is a little bit of a sad one, but it also comes with a happier ending, is that being in the position as a prescriber can really be challenging when it comes to relationships with clients. Clients rely on me for prescription, and so it can create this power difference, and I become a bit of a gatekeeper. And so many people in this position of power still have stigma towards drug users. We really want people to be abstinent, and it's just not what other people want. And so there's a real mismatch. And so I've really tried to work in a lot of ways to make sure that my practice is welcoming, and that I am trying to reduce that power imbalance that is happening with clients and myself. I did have some things that I've been changing about my practice, but I'm not sure if I should wait and maybe let Candice say how the things that she's learned about her practice.
It's wonderful, Joanna. I particularly, the point around the services and how they are designed. I think it speaks really to the importance of co-design and having services designed, with the involvement of service users or people with lived experience. And that's how you can try to ensure better success, right, in terms of access. So that's great. Candice.
Evening, friends. My name is Candice, as Michelle said, and I am a registered social worker. Very excited to be here tonight. Substance use, mental health, harm reduction, all some of my favorite topics to talk about, particularly with a group of like-minded individuals. So thanks for having me tonight, guys. I like the others, I think, you heard our bios, but a little bit more about me and kind of where I come from. And so currently I am working as a registered social worker on an acute mental health unit here in Hamilton. And I've worked in clinical roles within the hospital, both frontline and leadership roles, for just over 10 years, 12 years. Some of kind of the key roles I think that I've held that are important to what we're here to talk about tonight. I was thinking about it tonight. I was reflecting a little bit on what I was going to say, and I try not to think too hard about these things. Otherwise, I'll just scare myself and call in sick. So, I was reflecting on it though, because I feel like I've been very blessed to have the opportunity to be involved in a number of different projects over the years, and not because I've ever felt like I belonged there, quite frankly. And that's probably because of my history as a substance user. The truth is there's still a lot of, what's it called? Imposter syndrome that creeps in at times, right? And I think to myself still, after all these years and having the privilege of going to school, that perhaps I don't belong here, but some of the roles that I've held over the years, in the very beginning, of my career, I was part of the original development team for the first and only acute concurrent inpatient unit in Canada. And that was a really fantastic experience. We got to develop this unit from the ground up. And this was for a Catholic organization, a Catholic hospital, who at the time wouldn't even allow us to put condoms in the bathrooms, right? When we're talking about harm reduction, we weren't allowed to have conversations with people about birth control still, right? So we were up against some pretty serious barriers as we're talking about designing a unit specific for people who use substances. So I participated in that, and I had the opportunity as well to be part of the opening of our first RAM clinic where Joanna works here in Hamilton a few years back. I participated in the capacity building strategy across the Hamilton, Niagara, Halden, and Brant Lynn, where we focused on improving system access and capacity to support people with concurrent disorders. And then more recently, I had the opportunity to publish a paper with some of my colleagues on specifically looking at hospital policy as a harm reduction intervention for people who use drugs, and looking at how hospital policies are barriers for people who use drugs. And one more really important opportunity I had recently was participating in a research project that's still ongoing here in Hamilton. It's called the Second Heart Project, and it's working specifically with people who have endocarditis, people who inject drugs who have had endocarditis and have had valve replacement surgery. And we've provided 6 different interventions for those folks to see if we can improve treatment outcomes for a population that have really poor outcomes post-hospitalization. So have been very lucky to be involved in some of those projects, but I think, as has already been mentioned, being a woman in recovery from substance use is probably the lens that I lead with the most. I spent, just briefly, from the ages of 15 to 27, I was addicted to crack cocaine, and I spent a number of years in and out of hospitals, institutions, jail, with severe drug-induced psychosis, experiencing access barriers and stigma, and but at times also being treated with a lot of dignity and respect by service providers, right? So that probably is the lens that I still try to lead with the most. I'm still very active in the recovery community as well, and am very grateful. I see it as a privilege that I have 15 years of sobriety today, because it is rare, is the truth, right? And I say that, I think my key findings out of kind of all of that, the different scope of work that I've had the opportunity to do over the years, I was really thinking about it tonight. I didn't want it to be some like textbook answer, and I'm going to be real bold here. And I hope that this is going to be a safe space, because that's very important to me. I think that the key finding for me over the years has been to do my best to try to create a safe space for people to have really honest and raw conversations about our experiences, including some of the maybe like bad thoughts that we have, some of the things that we shouldn't be thinking about these people. It's really important for me to consistently process and self-reflexivity, right, around like, where is this coming from? Why am I thinking this? Having a safe colleague that I can go to. I'm very lucky as well that my leader at the hospital created that safe space 10 years ago for us to have these discussions, because I can't imagine not being able to do that, right? But having a colleague where I can go to and say like, listen, man, this is what I'm thinking, and like, I know it's like bad maybe, or it's not right, but like, this is what's going on, and really reflecting on like, where is this coming from? Why am I thinking this way? And so my I guess encouragement would be to do your best to try to create that safe space, right? I want to try to model that to the people that I work with, and use that. Otherwise, how do we learn, right? Like, how do we, if I have to keep that stuff inside, we need to bring light to it, right? And in a very, of course, with kindness and dignity and compassion still, right? No hate, but just in an honest, safe way for the purpose of learning in the future and providing better care. So yeah, that's a little bit about me. And oh, sorry guys, my grandma still has a home phone, if you can believe it. I live with my elderly grandma. I'm going to mute myself now. Thank you.
Thank you, Candice, for that transparency. Certainly appreciate that. And just segueing into the next question, really touches on stigma. So I want to ask the panelists, how has stigma related to substance use impacted access to harm reduction services?
I don't mind jumping in. I think that's why so many people don't access it, because of all the reasons that we've talked about, that people feel judged, people feel that they're not understood, and people also feel that there is some prescription for what they're supposed to do, that, well, if I'm going to go and access this harm reduction, I need to be abstinent, or I need to have this goal, or I need to be engaged in counseling. And obviously, if that's not your goal, then it creates reasons why you're not going to access those services. And so for us at the clinic, we really examined a lot of the medical model that's in place around accessing our services and how we actually do appointments. What are we asking of clients, and how is that leaving them with a feeling that they're bad people, or that continuing to use drugs would be a reason why I wouldn't accept them, to come back. So for me, it's about creating, like Candice says, this safe space that you can come in, and it's really hard to do, but there's a notion out there. Like, I was in a program the other day, and they were saying at a drug checking service that 60% of the people that were dropping off drugs to be checked weren't receiving any other services. So people are kind of picking and choosing places where they feel safe. So we have to create that environment where the word can get out that you are safe to come here.
Thank you for that.
I'd love to go next, if that's okay, because I know earlier when Andrea introduced me, she spoke about the fact that I am now at Moya Health and Community Services, and I'm going to speak from the lens of a person who is involved in trying to set up services, right? So when I joined Moya 3 years ago, work had begun to introduce a safe consumption site in the region of where our offices are. Of course, that dropped flat because of stigma. The landlord who was willing to rent us the space came under a lot of flack from the community, and even received some threats. So of course they pulled out. Now, 3 years later, or 4 years later, when I came, I said, this is something that we have to do. And as COVID continued, looking at the numbers and the impact that the drug crisis was having, it made it very, very clear to me as an executive that I had to do something. Together we have to do something. And so, we approached the region, the public health section. We spoke with the medical office of health, and we reignited the file, started on a journey, got approval for the funding. But today, I'm telling you, we have a list of about 45 sites. We've looked at sites within the different cities within the region with which I work, and we cannot land on a space for this. Why? Because one, the fear of some people feeling like, I don't want it in my backyard. It's going to affect my bottom line if I'm a business person. It's going to affect my house value, because it's, this is going to be bringing drug addicts into the area. We hear conversations about the fact that homelessness is going to increase, and homeless people are going to be loitering around these areas. We hear conversations about people's fear that they're going to be mugged and robbed because we're bringing a substance use program into their area. And we got approval. Council unanimously voted on this on the 7th of July. And I sit before you today on the 23rd of November telling you that we cannot find a space. Why? Stigma. A lot of people are saying, no, we don't want it near us. And so as we do this work, we continue to appeal to people to say, listen, there is a lot more at stake than how it is going to affect you. Actually, your community may even be safer because of the plans that we're putting in place to maintain community safety. Just open your mind and listen to us. But we still haven't been able to make a headway. We're not giving up though. Don't ever think that that is a sign of waving a white flag. By no means. And so I'm appealing even to those of you who are listening, if you know of space that we can probably touch on our access, I'd love to hear from you, because we want to put a space that people can use safely and know that they will be cared for.
Thank you for that. Hope.
Yeah, if I may, Michelle.
Go right ahead, Candice.
Thank you. Yeah, Hope, we're having the same struggle in Hamilton as well. They got the funding for it. In fact, they got funding 3 years ago. I hope it goes better for you now that you've been approved, but it's been 3 years, and they've found a location here, but there's a significant community outcry about it and a lot of protest that is happening as a result. This is a great question. You know, when I think about working at the hospital and the paper I just mentioned that we wrote, it's people who use drugs actually are 25 to 30% more likely to leave hospital early, to discharge early, against medical advice is what we typically call it, right? And that's for typically because of stigma that's happening, or because of so there's stigmatization that's happening, or inadequate pain management, withdrawal that's happening, and again the stigmatization of like security services being subject to room searches and security checks and discriminatory surveillance from staff at the hospital. So it's, and typically what's going to happen is that what we're seeing is that people are admitted to hospital, and they're leaving early for these reasons, and they're not getting the care that they need, right? And so in addition to, when this could be an opportunity really for us, right, to be connecting with people. But as I think Joanna already mentioned, the relationship between service providers, specifically the hospital, I'm going to speak to the hospital, the relationship between, there's not a lot of trust there, right? The service, people who use drugs don't necessarily trust the hospital, and with good reason, where often people are admitted to hospital, and as I mentioned, if they're drug users, right, they're not, a lot of physicians aren't comfortable prescribing higher doses of pain medication, which is often required for an opiate user, right? They're just not comfortable with that, so their pain is being inadequately managed, or their withdrawal goes untreated, right? And in our paper, we actually recommend 7 different interventions. I won't go into them all, but I think one of the most, in addition to like having addiction medicine consultation services available, I think one of the best recommendations that they made is that they're exploring here in Hamilton. We did get the approval from it, and it was supposed to open prior to COVID, and then we all got kind of distracted. We had to pivot, but was a safe consumption site in hospital for people who are admitted. So it's only for people who are admitted. It's not community-wide access, but having a space where people can go and use their substances so they can stay in hospital and get the help that they need, right? So it's an ongoing process, definitely, but I think I am seeing, I'm not in leadership anymore. I'm not in executive leadership either. It's happening. It's definitely happening. Change is happening at that level, I think, where like at a systems level. And I think it's really important that we as individuals continue to explore our, and implement it at our level as well, reducing some of those barriers and the stigma. Yeah.
Wonderful. Thank you for those insights, Candice. So when we think about strategy, why is it important to consider harm reduction as a part of a comprehensive prevention strategy? Hope, do you want to get us started with that question?
Sure. I love this question, Michelle, because I think when people think harm reduction, and of course, I'm going to defer to the experts who are treating, but a lot of times people think of harm reduction as abstinence, right? Harm reduction isn't abstinence. And we're talking about it in the context of drug use tonight. So I want to focus on that. Why is it important? Because one, if we have practices that allow people to use safely, we're going to have a healthier community, right? Joanna won't be seen as many people, neither will Candice, but hospitals won't be filled if we're looking at harm reduction from a preventative lens. We're preventing harm. We're treating the person as a whole and looking to their needs rather than condemning them. If we're looking at harm reduction in a non-judgmental way, then we're seeing the person. We're not being bogged down with the behavior, and we're looking at that from the perspective of how can I assist this person in taking a step in the direction that they want to go, right? Not forcing them down a path that is not on their list of choices at this point. I think also in terms of how is it good as a strategy, one, it helps empower people who are using. For example, I look at Moya where I am so proud of my team. Oh my goodness, I think I have the best harm reduction staff in the entire province of Ontario, because I have people who are compassionate. I have people who have the lived experiences. I have people who will move heaven and earth to help people in need when it comes to substance use. So if we look at harm reduction as a strategy, a preventative strategy, what it means is that we're going to be going the extra mile. I love the fact that we can call on people who, you know, Candice shared so vulnerably, and thank you, Candice, for your honesty and bringing these frank discussions to us, because at my organization, I rely a lot on the people with the experience, because their voice matters, you know, and I will say to them, what do you think we need to do? Because I may be the executive director, but let me tell you, I don't know it all. I really don't. And even when we wanted to re-embark on reopening the discussion about putting up the site, I sat with my staff and I said, this is a goal I have. What do you think? Because I couldn't keep looking at the numbers of deaths and, you know, ignore them. I had to say, let's do something. So from a strategic point of view, it meant that you've got to be invested, but at the same time, you're saving lives. You also have to put policies in place. So, you know, I think, for example, we're working on something now about decriminalization of drugs, right? If you're looking at it from a preventative perspective, what will happen is that people who use will be allowed to have a certain amount and will not be thrown into jail because they're found with substance, right? So they're not going to hide to use, they will be allowed, they won't be fearful of the police or being caught, because they will be respected for their use, right? So I think these are some of the things. Without those strategies, what will happen is that people go underground, people lose their lives, people continue to use and use alone or use in unsafe ways and unsafe places where they're at risk. And so at the end of the day, you're looking at a life. You're not just looking at a user, if you see the difference, right? So I guess I'll stop there. I mean, I have, this really is something that's dear to my heart, and I feel really deeply about the fact that all programs that are community-based should have some amount of harm reduction practices within them, because it is so prevalent and people are crying out for it, for a place where they can feel safe, where they can go and talk to somebody. You know, Candice said it earlier, for me, I will check in with my team and I'm like, this is what I'm feeling. Do you think it is okay? And they're like, oh, we've never had a director come to us. And I'm like, no, I need help. I'm human, right? And so I've had to overcome some of my own, because even the concept of decriminalizing drugs at first, I had to work through that in terms of understanding, and they were able to help me. So once I got to understand that better, I embraced it as a strategy. Right, so I will pass it on to another of my colleagues on the panel.
Thanks, Hope. So I saw a couple of questions in the chat here, if I could address those first. So from Arwin, oh my gosh, I need my glasses. The question for Candice: I had a brief moment of excitement about the idea of a CTS in hospital. But if I understand you right, that would be in place because prescribers are unprepared to offer appropriate pain management care to people who use drugs who are hospitalized. Thank you for the question, Arwin. Sorry if that is what I conveyed. Not specifically, no, it doesn't directly have to do with because prescribers aren't comfortable providing adequate pain management. That's a component, but it would be, there would be no, simply it's there in the event that people want to use substances. Has nothing to do really with that. We have an addiction inpatient addiction consultation service who comes and they do the pain management now. They're prescribed an addiction medicine team who will come and prescribe the higher doses that are needed. But no, it's not about them for the purpose of them not being able to prescribe higher doses. It's just to provide access, simply to provide access for people. And then I think the other question there, asked the panel to comment on the approach of safe supply. Yeah, so that is our addiction medicine team will come and see anybody who's admitted to either medicine or our mental health units, and they will prescribe safe supply. So specifically, prescribing morphine at times or Dilaudid to patients who meet a very specific criteria. I can't tell you, I'm sorry, I can't tell you what the criteria is. Joanna, you might be able to speak a little bit more to that. I'm not sure if that's something that you do at the RAM clinic.
It's not something that we do at our RAM clinic, but I don't know if now's the right time to comment on it, I think, but it's here. So I would just say that all of these are tools that need to be offered to clients. So my impression that I get from clients is they all have goals. They have somewhere they want to be, whatever that goal is. And we are only providing them with a small number of options. They know themselves, like I said in the beginning, what they need for their own care, what they need for their own community, their own family, but we're only providing them with a select few options. And when we do that, and then people don't want them, we're surprised. Oh, well, we're offering this thing. It's like, but that's not what someone wants at this moment in time. So safer opioid supply is absolutely necessary for certain people. Not everyone wants that. Like, I have many people who genuinely come in, I would want to stop substances, I want your help, and we're going down the treatment route. But we also alternatively have to have those other avenues for people who aren't ready for that. And we have, I can speak from it kind of from the medical side, that there is this conflict that is happening between the two groups around treatment versus safer opioid. And it doesn't have to be binary. They can all exist, and it's a menu that we give. And if I can't do it, like I don't do safer supply, that's not in our program, but hey, I'm going to find that person for you because I have the connection and the community resource. So that's where it comes in, to have your own community of clinicians that if you're not comfortable with something, I'm going to own it, but I'm going to send you to Hope or Candice because they're experts in X, Y, or Z. So, you know, people want help, but we're not providing it exactly how they want it. And so that's where everyone's been talking about, let's get people who are using the services helping to design it so that it actually gets used and it can actually be helpful. And in terms of like harm reduction as a prevention strategy, Hope, you mentioned having safer use supplies in all community practices, and that has been something that we now have in our community clinic. So beyond naloxone kits, we actually have safer use kits. And what's been incredible for me is actually working with clients about the safe use kits. And it's been this amazing tool for engagement because I'm learning and they're learning and we're laughing and we're kind of fumbling through this interchange, but it creates this space where like, I'm a person, I'm interested, they're a user, they want to be safe. And it's kind of this match. And it takes me out of being the power person and I'm the learner now. And so having safe use supplies as a tool for engagement for me has been really incredible and something that I would certainly encourage other kind of community-based clinics to have. And the other thing is when we talk about that, it helps me understand the multiple substances that people are using, because people aren't just using, say, opiates, then they might use a stimulant to help them come up. If I don't know all that information, then how can I help them be safer around combining those medications? So that's where strategies like talking with clients honestly about their use, about drug checking services, so we actually know what's in everything and I can counsel you better. So harm reduction as prevention has so many layers. Thank you.
Thank you for that, Joanna. You started to touch on drug checking programs and services. I wonder, and the question is for all of you, what do you think the role is for drug checking programs such as fentanyl test strips and drug checking services? There are a number of services that are set up with email notifications, and they're posted on community sites. Can you speak more to that?
I don't know if you wanted me to do that or somebody else, but I think people want to make informed decisions, and the only way to make informed decisions is if you actually have the information. So again, it's really about providing someone agency over making a decision about, am I going to use today? Am I not going to use today? Am I going to use this batch? Am I going to maybe use Suboxone for a few days because I don't actually want to use this batch of opiates, right? So really, it's just about providing clients with information so they can make their own decisions. And then if we have a more organized service, then we can actually share with people like, okay, but there are some drawbacks, right? Like, so just because this batch says it's safe, you know, we have that whole kind of chocolate chip cookie, you know, analogy that's been used that, well, that could just be that batch, you know, we didn't pluck out the, you know, 70% fentanyl opiate. So again, just another tool for decision-making for clients.
Wonderful.
And if I could speak a little to it. So one of the things that Moya does well is engage the voices of people who use substance. We have a group of substance users who are part of an advisory committee who work with us, and they keep us well informed as well as accountable, right? Now, one of the things we've been talking with them about and hearing from them is they feel like a drug checking system would really be helpful, because a lot of people are getting street drugs, are getting stuff from their friends, or, you know, just buying from somebody, again, because it's nothing that they can do openly. And unfortunately, sometimes the batch that they get may be laced with other things. And this is what is leading to some of the problems. So for us, our goal when we open this safe consumption site is to be able to provide some type of testing for the substance that people use. So when they come in and we're working with a group now, an organization now, to see if we can make that happen if and when our, not if, when our SCS comes on stream. I've got to take that if up my head because it's gonna happen, right? So we want to also ensure that people know that if they're using something, if they're not getting it from a secure supplier, then what they're using is not going to hurt them in any way.
Thank you, Hope. There's a question in the chat. You know, we've talked about, you know, as we're talking about harm reduction, we've already, you know, solidified that harm reduction exists on a continuum. The question from Pam is, what is your relationship with the abstinence community?
I'll take that if I can. I just want to acknowledge that there are a couple of other questions in the chat as well. And I believe that shortly we're going to open this up mostly to questions, right, Michelle? Yeah, okay, great. So we see you and we'll get there definitely. This one stuck out for me because, as I mentioned before, I am in recovery. I'm going to use the word clean because I'm part of a recovery community that does use that term for 15 years. And I did get clean in an abstinence-based program. And it's, you know, the reason that I get nervous when I say this in front of such a large group, the reason I talked about it earlier about creating a safe space is because the truth is that I was not always an advocate for harm reduction, you know, particularly because, you know, I found sobriety in an abstinence-based program. And oftentimes we use ourselves as a frame of reference for things, right? So, you know, it took some time for me and some research and some experience to think otherwise, you know, and even still now though, like I mentioned before, having this safe place to say things out loud, why it's so important is that there's still times now when I think to myself, you know, I don't know if somebody would have, I don't really ever remember being offered harm reduction services when I was using. There was a lot of shame that I experienced from it. And, you know, spending time like hiding in doorways to use and terrified. The majority of my psychosis came from fear of the police, right? And being arrested again and having my house raided again. And so I hid and I was underground and I don't recall ever being offered harm reduction. And I often ask myself, like, I wonder if my trajectory would have changed if somebody would have offered me harm reduction. Like, would I have gone the abstinent route, you know? And I have to take that a step further and ask myself why I think that that's the best method for everybody, because that's the truth. At my core, I think to myself, like, but look at the life you could have. Like, it's great. Like, my life is great. You could be me, you know? But where does that come from? Why do I think that that's the only way? And really sitting down and processing where my thoughts come from and having a safe person to process this with helps me think otherwise. And it's been years of, you know, talking with people, being honest, working, talking with clients like Joanna talked about, you know, and to learn from them really about how important harm reduction is. And I have to say that, you know, it did, I remember when harm reduction, like specifically opiate replacement therapy, was offered more as it was kind of a last line intervention, right? It was typically thought of for people who we'd tried everything else with and nothing else worked, including abstinence, right? So now we're going to offer you this because nothing else has worked. Whereas now it's a first line intervention, right? Evidence suggests that we want to be offering people Suboxone or methadone right away, right? And I think to myself, again, it comes up, I'm like, oh, but like, how about a meeting instead? I know that sounds crazy, but just being honest, right? But the reality is that the climate has changed for substance use, right? Like when I was using, we didn't have fentanyl on the street. I was lucky. I bought crack. I got crack, you know, and that's not how it is today, right? People are dying. People are dying every day off of one use, you know, so we have to offer it to people. It's a very different environment than it once was. And it doesn't mean never, it just means that this is where they're at now. And we're trying to meet you where you're at, you know, creating a relationship with people so they feel trusting and they might be willing to explore something more. Holding, I feel so cheesy when I say this, but holding the hope for people when they have none, right? Like oftentimes people, I think they don't believe that perhaps that there might be a different way, you know, if they can, anyhow, I'm going off on a bit of a tangent, but that's my, you know, my relationship. I don't always, even though I just want to finish off with saying, despite, I always say to clients when I'm working with them, I do use self-disclosure when it's appropriate. And I always am sure to let people know that just because I got sober this way doesn't mean that you need to, right? It's very important for me to say that to people and to understand that people do have the freedom to make their own choices, right? I don't always invite people to a meeting. I don't give everybody, you know, abstinence-based resources because I don't think everybody's appropriate for it. That's not where they're at, right? I'm really looking at somebody in their stage of change to gear my interventions towards where they're at. Yeah. So thank you.
Absolutely. Thank you for that, Candice. Okay, I want to go back to a question that David posed in the chat. David states that they're curious about the possible drawback of harm reduction models of intervention and the role of trauma-informed approaches as an adjunct. So here we have the intersection of harm reduction models of intervention, and then the role, what is the role of trauma-informed approaches play alongside that?
I'm not sure. I really struggle to find a problem with harm reduction. So I'll think on it though. But I just wanted to say that I actually think harm reduction is very trauma informed because it doesn't prescribe for anyone what they should be doing next, but instead honors whatever experiences that you've had. And this is where you are today, and offering choice. And I think those are some really fundamental aspects of trauma-informed care. You know, we want our harm reduction services to be safe, to be somewhere where people can share their story when they're ready. And so I do think that that actually meshes really nicely when harm reduction is done well. I would also say, just in terms of trauma informed, like it's been really interesting. We now have a trauma therapist on our team, and it's one of the offerings that we have for people. And as I've gotten to know people, I've realized like so many, even though it's offered and we think, wow, who wouldn't want to take that on, this amazing opportunity to really, you know, work through some of their trauma in an evidence-based way. But so many people have been so hurt and are not ready for that. So just providing the foundation is the primary thing. And I do kind of feel that harm is that foundation where there is no expectation for a next step, but let's keep you the safest you can be today and see where that leads us in the future.
Absolutely. That does definitely mesh well, providing people with the opportunity, providing them with information to make informed decisions and those choices for themselves. Anybody else want to comment on that question?
I was just thinking sometimes it's what comes first, the chicken or the egg, right? And I kind of struggled with the question a bit because I wasn't sure, you know, I know, David, you're asked about it as an adjunct, but sometimes some people see it as one or the other. And so for me, it's starting with where the individual is at. a lot of times people, trauma is not something that comes to the surface easily. And it's not something that people are really willing to work through initially. You have to be ready to do trauma-informed care. And so that's kind of what I'm thinking. Sometimes the impact, a lot of times decisions are made based on either the pros or the cons, so the benefits or the consequences, right? Somebody may make a decision, think of our lives, you're gonna lose weight, or we're good because somebody we know fell and broke their foot because, or something, or somebody had cancer, we're not gonna eat this, or we're gonna live better. When it comes to substance use, sometimes it is because of the impact that the drug may have on a person's life, or they may know somebody who had a real negative effect from using. And so sometimes that may be the first thing that they want to lead to, a decision to do something about the drug use. And then working through that will lead to a point where, offering trauma-informed care may become necessary. But I think it has to be that we're starting where the person is at. And if and when we do introduce or have to use trauma-informed care, it should be offered in a holistic way, in a respectful manner, in a manner that really respects and values the person for who they are and what their story is. It's different for everyone, and we can never be prescriptive about how we offer the support around that. And so that's kind of why I was struggling with this question, because for me, it's like, what comes first? And I want to be absolutely clear to everyone here that I do believe in both, but we have to start where the individual is at.
Oh, that's great. All right. We have another question in the chat by Arwen. And their question is to everyone in the panel. Can you speak to if or how community building and community development are fostered through your programs?
I'll start with that. So the last, before I returned to inpatient, I was working on a project for the hospital in the community it's called City Housing Hamilton, social housing units in the city. And I was managing a small team who we had funding for about a year to rapidly house 20 people from encampments into housing. And so it was the first time in our community that we were able to pair health supports with housing supports. And as you can imagine, there's a good chunk of the people who are coming from encampments who are substance users, right? So the idea, we had 4 nurses, 4 peer support workers, 2 addictions workers, and an occupational therapist and a peer support worker on the team. And they chose, they went through some of the data in Hamilton and chose 20 of the highest acuity folks from encampments and housed them in this building. And we paired them with community, with health supports for the first time to try to see if there would be positive outcomes in keeping them housed. And in fact, there were, at the end of the year project, 16 out of the 20 people were still housed. It was difficult, because we're taking people from encampments, and there's been a particular people are accustomed to a certain way of living and needing to, like some hoarding issues and kind of bringing other people into the home and things of that sort that needed to be worked through. But having the team available on site in the building really had proved that this intervention worked. So they actually used the outcomes of this, and the city funded, they got provincial funding and city funding for the project to continue on a larger scale. And so they're going to look at scaling this up over the next few years to continue to rapidly house more people. I suspect it may not be, unfortunately, I don't know that the city of Hamilton is necessarily going to be on board in terms of being a landlord this time, because as you can imagine, it's as a landlord, it poses some difficulty for them, but hopefully they can, with the right advocacy, that they'll be able to find housing for these folks and to pair them with house supports. I guess this has to do, Michelle or Hope, you might be able to speak more to this too, being that I haven't been that high up in leadership necessarily, but that the funding models are different for housing and health supports. So until now, they've never been able to pair it. What they did was they actually took COVID funding and did this as a pilot project and then applied to the government for more funding. So it did work. So that's how we work on like building community and community development with folks like this from a housing first model, really, right? Is kind of what it comes back to. Yeah.
Candice, I have a follow-up question for you with that. Was the community consulted and it being a part of the development of the program itself?
Sorry, what's that?
Was the community consulted in the development of the program that you've just described?
Yes, yeah. It's pretty standard now, usually, that thankfully in the roles that I've been in and participated in, that there's usually almost always members of the community with lived experience who are on these panels that we're consulting with. And when I say lived experience too, I'm happy to see now that even that has changed from, I think there used to be this expectation that people with lived experience were abstinent, right? And now there's roles for people who are still actively using drugs on these boards and these committees now. Very, very valuable experience to have. Mm-hmm.
So before we open the floor for more questions from some of the attendees, I do want to just give an opportunity for any one of the panelists to, if they wanted to add on to the last question.
I could just add quickly, in setting up the SS model, it's very important for us to definitely use a community and development approach. So in our model, what we're looking at, we have all facets of the community involved. We have public health, we have the EMS, and I spoke earlier about our advisory group of people who use substance. We have community health centers, so we are touching bases with everybody. We have our business owners, so we have the ones who commend, and we have the ascending and descending voices, right? So it's important to hear from everyone and to have their input as we plan this out, because we want it to be successful, mainly for people who use substance, but it also has to be something that the community embraces and supports, because that is going to help to fuel the success of the location.
Thank you for that, Hope. All right, so there's one other question in the chat, and then we're going to open up the floor, the virtual floor, for some more live questions. But the question from Gautam, I hope I'm pronouncing your name correctly. In the current political climate, how can the concept of harm reduction be advocated for in such a way that it resonates with resistant mindsets?
Maybe I can provide the first answer to this. I think this will remain a work in progress. It's not something that you're going to arrive at. This is a journey, not the destination. I know when we made our presentation to council, my closing statements were centering the individual and not the behavior. Let's look at lives lost. And, I close by saying, who knows, the next life you save could be a relative of yours, right? And I think that politics and principle are often conflicting, right? A politician or somebody who is resistant, a lot of times they're resistant because of what their public life wants to say, and not necessarily what they want to do in private. And so the resistance is brought about because of how they're going to be perceived, how they're going to be talked about, voted for, supported in office, or in a decision that they make. And so for me as an executive, what I do is look past that, and I acknowledge that, and I acknowledge it with them. I say, you know, I know this is difficult for you. However, let's have a conversation. Let's have a conversation. And one of the things that helps us tremendously, as we did our delegation to council, for example, we had people who helped to delegate who had lost a relative to overdose or to the poisoned drug supply. We had people who were themselves still using, but using and being healthy, who were able to talk about how much they need this space. And so I think it's just hearing from people who have been through it, and the impact that it has had on them, as well as looking beyond what resistance is being presented, and look to the need, and appeal to people. People have a conscience, believe you me. People will, at the end of the day, they're not going to want to feel bad if they know that this is about lives lost. And so every opportunity I get, I say to people, listen, the next life you save could be one of your own. Look at it. Even when we met with the group of the politicians and business owners, and they were saying, no, we don't want this. This is what it's going to create. And I said to them, you know, you're talking about this community. Usually people of affluence are sometimes, in the early days, those were the ones that had the funds to purchase and use, right? And so you have to realize that the places that really need it are there because people are using it. So don't be too afraid. So look beyond the hurdles, look to the issues, point them out, respect those who differ from you, but do not give up. Be consistent like a dripping tap, centering the person, because one day they'll get it.
What an engaging conversation. Some great points were made. I think some great insights. And I don't think that the conversation has to stop here. Tonight it does, but how does it continue on in the work that each of you do? And I'm talking about the attendees as well. What does that look like for you? Where do we go from here as it relates to the conversation in harm reduction? I want to thank all of the panelists for your time and for your insights and what you've shared with all of us today. And I want to thank all of those who have attended, to shown their interest in such an important topic that touches so many lives, especially now. Thank you all for attending, and take good care.